Welcome to ATSM, the Emergency Medicine channel. Shall I start, sir? A 43-year-old male patient, non-case of rheumatic heart disease, aortic regurgitation and mitral regurgitation, who done double valve replacement and was on is on acetrom and ecospirin, presented to the ER with complaints of fever with shivering, with malaise and generalized tiredness for the past 2 weeks, with progressive dyspnea which was worsened for the past 2 days. Initially he was evaluated in the outside hospital, and in view of hypotension they started on noradrenaline support, and with all blood investigations they shifted the patient to our ER for further management. On initial 10-second assessment, patient is conscious oriented, airways patent, breathing is respiratory rate of 38 per minute with saturation of 80% in room air, and just bilateral basal crepitations were there. So we started on O2 support on face mask. We put the patient in propped up position and started on O2 support face mask with 5 liter O2. And coming to circulation, BP is 120/80 with 4 ml per hour noradrenaline support, and pulse rate is 125 per minute. And GCS is 15/15 with pupil bilateral equal and reactive, and temperature is 99 degree Fahrenheit. And we give one injection paracetamol 1 gram IV stat.
When the temperature is normal, why did you give paracetamol?
So 99.
99 is normal. Normal or abnormal?
98. 98 and
99 is normal.
when we check, we felt it as febrile aversion.
When will you give paracetamol as IV? What are the indications for paracetamol IV? If you want to justify this action, you can justify. That's why I'm asking.
It's more than 100.
Paracetamol tablet is enough. What is the indication for IV paracetamol?
If the patient is not orally tolerable.
What is the newer guideline of paracetamol along with antibiotics? What will happen to antibiotics? What is the new guideline? Recent WHO has given a guideline.
Action.
Fever is a protective mechanism. So when you are giving a paracetamol along with antibiotic, the efficacy of antibiotic is going to down. Okay, but there are some certain definite indications for paracetamol that you should know. So you cannot hold paracetamol in such situations. What are those conditions?
Febrile
Seizures, febrile seizures, or seizure with temperature. Then post-cardiac arrest. Okay. Then heart failure. Fever with anemia is not an indication. Anemia itself will produce fever. There is not an indication for paracetamol. Cardiac failure, coronary artery disease, acute coronary syndrome, stroke, pregnancy. These are the indications for paracetamol. Otherwise, paracetamol is not going to really help the patient. It is only going to prevent feverish symptoms in the patient, body pain, something. Okay. Otherwise, it is not justified. That's all.
And we took one CBC CRP point of care which shows total counts of 14,000 with neutrophil predominance of 82% and HB of 10.6, platelet is 60,000 and CRP is 116. Male patient.
10.6 is a safer limit of hemoglobin or not safe?
Means in males.
CAD patients.
In CAD patients have to keep at 10.
So 10 is a safer, it's a safer area, but it is less in this patient.
And ABG is taken which shows pH of 7.483 with a PCO2 of 17 and PO2 is 45 with a bicarb of 17.9 and
abnormality,
with bicarb is 17.9 with PCO2 washout is there in respiratory alkalosis phase with PO2 of 45. Type 1 respiratory failure is also there with a lactate of 4.2 and sodium is 123 with
lactate is elevated due to
maybe because of hypotension, perfusion and also tachypneic also.
It was on noradrenaline.
Noradrenaline
and BP was maintained.
Maintained.
So how do you explain this lactate elevation?
Patient is tachypneic and also maybe because of hypoxia.
Tachypnea is enough. Okay. Either because of the hypotension, but that was corrected according to you, and hypoxia is one of the causes for high lactate.
And creat is 0.8. And we took one ECG which shows sinus tachycardia and chest X-ray also taken which shows features of pulmonary edema, and also left lower lobe patch is there with the bilateral mild pleural effusion is also there. And coming to ample history, patient is not allergic to
lower lobe patch.
Left lower lobe patch is there. And patient had been apparently asymptomatic in regular follow-up in outside hospital after double valve replacement in 2008.
What is vanishing lung syndrome?
Because of the cardiac.
I asked whether it is left or right. Should get a clue from that itself.
Cardiac vein.
Vanishing
the
lung
left side.
syndrome. You know, right side there is an interlobar fissure. Most of the pulmonary edema cases, that interlobar fissure will be either filled or prominent. Sometimes it will be large. Okay,
because of
especially in a
that,
chronic heart failure. If you give short Lasix, after sometimes it will disappear. Okay, that's why I asked you whether it is right or left shadow. Left shadow will be more like a consolidation or collapse, atelectasis, something like that.
And developed high-grade intermittent fever with chills for past 15 days with fatigue and loss of appetite with shortness of breath worsened to grade 4 over the last 2 days. There is no history of chest pain, no history of orthopnea or PND or palpitation, no history of recent dental procedures or IV drug use or any invasive procedures. There is history of mild cough with expectoration, no history of urinary symptoms, no bleeding manifestations or melena. And on examination, patient is conscious oriented, febrile with pallor and mild pitting pedal edema is present. No cyanosis or clubbing or no lymphadenopathy. Coming to respiratory system.
Mild pitting pedal edema, is there a classification like that? Should be very clear when you are presenting a case. Okay, when you are practicing, you can tell mild, moderate, severe. But is there a mild pedal edema? It is not that. Pedal edema, pitting or not present.
And coming to respiratory system, bilateral basal crepitations with reduced air entry in the lower zone, moreover the left side, and CVS S1 S2 heard with an early diastolic murmur in the left, the aortic area in the left sternal border around.
Early diastolic murmur. Okay. How do you describe an early diastolic murmur when you are practicing with your stethoscope? Don't tell echo shows that this. You are telling early diastolic murmur. That's why I am asking. What you are suspecting? What is there in your mind when you are getting an early diastolic murmur?
Most probably regurgitation.
Okay. So is it aortic regurgitation or something else? How do you know that it is aortic regurgitation before doing echo? What are the other features of AR?
There will be high pitch decrescendo murmur and it will be
peripheral signs.
Aortic regurgitation.
Wide pulse
pressure.
Wide pulse pressure, very high volume pulse.
High volume.
Then early diastolic murmur. S1, S2, what will happen? AR, what will happen to S1, S2? S1, S2, what will happen? Aortic regurgitation, nothing to do with the S1. It is originating from the mitral area. S2 may be masked sometime. Maybe, not sure, maybe masked. What will happen to the ventricle size?
It increases.
It is increases. So these are the signs you are supposed to tell. If you want to tell that it is AR. It is just a chemic murmur or because of anemia it creates a murmur means nothing.
And parabdomen soft and no hepatomegaly or splenomegaly and non-tender.
This patient is valve replaced mitral and aortic.
Both valve replacement.
Getting a murmur in that area, aortic area or subaortic area is very, very critical. Okay, you want to know whether it is an infective endocarditis murmur, the valve is leaky because of infective endocarditis. That is very important.
And CNS wise, no focal neurological deficits, and in that point we also we suspected any infective endocarditis since the patient we initially suspected LRTI with lower respiratory tract infection with hypotension and pulmonary edema with bilateral pleural effusion and type 1 respiratory failure. Since the patient has a history of prosthetic valve replacement, we also suspected infective endocarditis. And we informed cardio also, and we done one
cardiac
echo.
Failure is no infective endocarditis alone. You cannot suspect. You are going to suspect infective endocarditis with cardiac failure. Okay.
and we done an echo which shows a mobile echogenic mass attached to the prostatic valve in the aortic area, and also mild valvular leak, both aortic and mitral. Mild valvular leak is there with a good LV function, and dilated left atrium is also there. And we managed the patient. Initially, we started on O2 support and noradrenaline support.
How do you manage this case in emergency room? You cannot replace the valve. You are not a CVT surgeon. How do you manage this case in emergency room? This patient is having by both the valves are replaced. Now coming with a possibility of leak, valvular leak, and pulmonary edema. How do you manage?
For pulmonary edema, we can support with NIV, and also we can start on laxus infusion.
When you are starting NIV, what all things you have to take care here?
Since the patient blood pressure is low, so
you have to be very
there is chance for
further hypotension.
Okay. And also we can start on laxus as infusion. As infusion, and also we have.
Why don't you give Lasix push?
Since the BP is in the lower side, if we give a large dose,
Lasix as a push, then there is a further
chance
reduction in the BP. So you better give
infusions. We can also take care of electrolytes also. Since the patient VBG shows sodium of 123 and potassium is 3.2.
You want to correct?
No sir. No sir. Patient is fully conscious oriented. Since we are starting on laxis, we have to monitor the electrolytes also.
You want to correct sodium?
We can wait
you
for
want to correct or not?
This fluid overload is also there, so we have to check for whether it means serum osmolarity, urine osmolarity, and urinary sodium. And
no, I just want to ask you whether you want to correct this hypernatremia with 3% solution saline or not.
No.
Better not, because it's only a dilutional hypernatremia. We should understand that there is only dilutional hypernatremia. Patient is asymptomatic on that aspect. Better not to correct. You get a complete diagnosis, then you can probably correct it. Okay, what is the urine sodium?
Urinary sodium is around 40.
40. Okay, slightly elevated more than normal. What may be the reason for that? What may be the reason?
Patient on laxis.
On Lasix. Okay. So suppose you want to prevent that urinary loss, or do you want to continue Lasix? What other drugs are an option here? And that drugs are recently used in cardiac failure. It is used in hypernatremia also. What is that drug? SGLT is a different this one that used in diabetic patients with cardiac failure. Here, what else you can use?
Tolvaptan.
Okay, tolvaptan is having like a capacity to remove water, hold the sodium into the body. So that may be a useful drug, but here it is not an issue. Patient is absolutely normal. Mild hypernatremia may be possibly due to dilution. Okay, so just ignore it.
And in outside lab reports, INR is around 9. 9. And
he was on acetron.
And in our INR point of care, it comes down to be 8, and lab INR comes out to be 5.7.
So how do you manage that INR very high and patient is a leaky valve, replace leaky valve? What do you do?
We can hold the anticoagulants, and also we can, since the patient is on acetron, we can, if there is any bleeding chance, and also if want to do any invasive procedures and all, we can give injection vitamin K, and also we can.
Acetron is a vitamin K antagonist.
Super. Means warfarin.
Warfarin is a vitamin K. I don't know whether this will
is
respond
also
to this also
warfarin, vitamin K. And also we can arrange FFP and we can transfuse.
Immediately can give FFP and slightly revert it back to like INR. Maybe what is your range in a replaced valve? 2 to 3.5. Okay, that range you can reduce. Okay, not to normal.
And we also take blood cultures from 3 sites, aerobic and both anaerobic cultures, and we started on empirical antibiotic.
What empirical antibiotic you start when you have suspected infective endocarditis in a replaced valve?
We can
what is the empirical antibiotic you start in ER?
We can start on penicillin groups, and
What is the guideline? Penicillin groups are started in a normal infective endocarditis, where there is not a, it is not a replaced valve.
Penicillin groups or ceftriaxone or if
What
I
is your
suspecting
opinion?
MRSA, vancomycin.
Vancomycin.
Vancomycin is the drug of
Suspecting
choice.
MRSA.
Okay, whether it is afterwards, once you make a diagnosis, complete culture shows vancomycin sensitive, penicillin sensitive, you can shift. Vancomycin is a choice in emergency room as an empirical treatment. Vancomycin with ceftriaxone. Okay. Prosthetic valve.
And we started on antibiotics and we sent the further lab values and admitted in
Is there any problem
CCU.
here for vancomycin? Creatinine is normal?
Creatinine is 0.8.
Point.
In case of infective endocarditis, it's a microbial infection of the heart valve or the endothelial lining because of the presence of bacterial or fungi in the blood and also intracardiac surface on which there is a microorganism can attach. And the predisposing factors is like congenital heart disease, VSD, PDA, and TOF and coarctation of aorta, and rheumatic heart disease in case of ASMR and AR.
Which are the heart diseases which are resistant to infective endocarditis? Resistant means the less incidence, less risk, cardiac lesions.
AST.
AST and one more. MS or MR? MS. So there are less turbulent lesions. AST and MS. Whereas MR is more turbulent, AR is more turbulent, AS is more turbulent. They all produces damage to the ventricular wall. Okay.
And any prosthetic valves, IV drug abuse and all, there will be risk, and indwelling IV lines for and pre-existing structural abnormalities.
IV drug abuse will produce which wall?
Tricuspid. And there is also an amarantic endocarditis, which is an uninfected vegetation in patients with malignancy or chronic diseases. SLD. And the most common organisms are Streptococcus viridans and Husk, Haemophilus, Actinobacillus, Crediobacterium, and Echinelli and Quinquenelli, and Streptococcus bovis and Staph aureus. And gram-negative bacilli is also possibility. And clinical features will be fever with chills and we can appearance of new murmur or changing murmur. There is possibility of cardiac.
There is a murmur. In a prosthetic valve, you should never get a murmur. If you are getting a murmur means there is something, obstruction is there, possibly infective endocarditis.
And we can also see cardiac complications like valvular insufficiency and heart failure. And we can see cutaneous embolisms and Janvey lesions that's seen in palms and soles, which are non-tender. And these are the microabscess with neutrophil infiltration of the capillaries. And neurological complications will be seen in 40% of cases like embolic stroke, intracranial hemorrhage, brain abscess, metastatic infections like vertebral osteomyelitis, septic arthritis, psoas abscess, and also splinter hemorrhages over the nails, petechiae. Can be seen splenomegaly and Osler's nodes, painful tender swollen nodules of the pulps of fingers, and road spots, circular retinal hemorrhages with white center. And Osler and road spots are seen in case of severe bacteremia. It's a sequelae of the vascular occlusion by microthrombi, and we can also see hematuria as a part of systemic immune reactions. Glomerulonephritis can be seen, and septic emboli, infarction of the kidneys, spleen, and other organs can be seen. And there is acute and subacute infective endocarditis. Acute means patient presented with a rapid progressive cardiac damage and all will be there. And there will be hematogenous blood. It's a complication of the infective endocarditis, change into leaky. Sudden.
Here valve is opening and it is leaking. Closing. Sometimes what will happen, valve will not open. So patient will develop pulmonary edema. Okay, so that is a surgical emergency. Immediately you have to do something. Okay, that will not be resolved with the medicine.
In case of subacute, patient will be presented as a mild fever, like an intolerant cause. Initially will be treated as pyrexia of unknown origin and all. There will be slow progression and all. And in 2023, the Duke criteria came into picture, infectious modified Duke criteria. That is either two major or one major plus 3 minor or 5 minor. In that, we have to take the blood culture that is with the typical microorganisms consistent with 2 separate blood cultures in absence of primary focus, or microorganisms consistent with the infective endocarditis persistently positive blood culture. That is at least 2 blood cultures drawn more than 12 hours apart, or all 3 or a majority of more than 4 separate blood cultures. And other criteria, single positive blood culture for Coxiella burnetii or antiphase IgG antibody titer more than 1:800. And also evidence of endocardial involvement that can be seen in the echo, and the new additions are like CT and PET CT.
Okay.
And minor criteria like predisposing any heart conditions with a fever more than 38 degrees Celsius, and already we discussed the vascular phenomena and also the immunological and microbiological evidence. So we usually do the complete blood counts, and there will be increase in ESR and possibility of anemia with the urine, possibility of microscopic hematuria and proteinuria will be there, and blood culture we have to take 3 sets of blood cultures. That has to be from separate sites at least 1 hour apart, with and optimal volume of blood is 20 ml. And we have, if the culture is negative after 48 to 72 hours, we have to take 2 or 3 additional blood culture sets. And during treatment, blood culture should be repeated daily until it's sterile, and we have to perform again 4 to 6 weeks after the therapy. And there is also a culture negative endocarditis is also there.
The role of transesophageal echo in this patient.
Transesophageal echo will give an information about this vegetations and also the cardiac function.
This is the best mode of echo, but we cannot do it here. We have to take the patient to the cardiology.
And in ECG, we can see conduction. If we see conduction delay or heart block, there is possibility for the paravalvular extension of the infection to the adjacent septum and valvular annulus. And more sensitive is transesophageal echo, but and better detection rate is also there. The treatment we already if it is streptococcus, we can start with penicillin G 2.3 million units IV 4th hourly for 4 weeks, or penicillin plus gentamicin combination. Gentamicin has to be given for initial 2 weeks, or ceftriaxone plus gentamicin.
Give a gram positive coverage, coverage. Then transplanted valve or repeated hospital admission patient,
better to start on
for vancomycin with ceftriaxone.
And surgery in patients with fungal infection, and if the patient is not, if it is the patient is to the antibiotic resistance and all, and there is persistent infection after 1 week of therapy and 1 or more embolic events during
gentamicin is normally a single dose drug. In infective endocarditis, it is given a single dose or multi-dose.
8th hourly.
Why it is like that? Normally in our other case, you give gentamicin as single shot. Okay. It's a dose-dependent killer.
It's a continuous bacteremia.
Since it's a continuous bacterial
load in the
floating in the blood, you have to give continuous infusion, either continuous infusion or repeated doses. Okay. That will have a better coverage than a single shot. So this is the only condition where you give gentamicin, vancomycin, or multiple doses. Otherwise, single dose alone is enough.
And also prophylaxis is indicated in case of prostatic valves or previous endocarditis or unrepaired cyanotic congenital heart disease, and even if it is completely repaired with prostatic for the first 6 months and all, we have to give the prophylaxis. So the prophylactic also in case of dental procedures, respiratory tract procedures, and genitourinary or gastrointestinal. So in case of genital and respiratory tract procedures above the diaphragm, we can give the gram positive agents, and if it is below the diaphragm, we can give gram negative agents. So gram positive, we can give amoxicillin 2 gram orally 1 hour before the procedure in children 50 mg per kg dose, and otherwise we can give ampicillin 2 gram IM or IV within 30 minutes. If it is allergic to allergy, we can give clindamycin 600 mg, azithromycin or clarithromycin. And in case of genitourinary, we can give ampicillin 2 gram IV IM plus gentamicin combination, followed by ampicillin 1 gram IV or IM or amoxicillin 1 gram orally 6 hours later. If it is allergic, we can give vancomycin plus gentamicin combination.
So any infected valve replaced while coming to emergency room, you are putting catheter or any other procedure, better to give antibiotic prophylaxis. Only thing you have to see, what are the high risk patient, what are the low risk patient, that category is there, that you have to find out. Anything else? What do you want to add? Nothing. She has presented well. Okay, nothing to add more than that. Okay. Thank you.
Thanks.